Hello, and welcome to this afternoon's Ask the Expert webinar. I'm Mike Knoppen, the Program Director of the Myotonic Dystrophy Foundation. We're very excited for today's presentation, Ask the Expert, a community portrait through surveys and insurance claims data. Now I'd like to tell you a little bit about the Myotonic Dystrophy Foundation. Our vision is a world with treatments and a cure for myotonic dystrophy. Our mission is community, care, and a cure. We support and connect the myotonic dystrophy community. We provide resources and advocate for care. We accelerate research toward treatments and a cure. The Myotonic Dystrophy Foundation is pleased to offer a number of free, accessible resources for our community, including our toolkits and publications, including information about myotonic dystrophy, Social Security disability, and much more. You can find these resources at myotonic.org/toolkits-publications. We understand how important it is to connect with other individuals in the community, which is why we offer a wide range of support programs. You can find those programs at myotonic.org/find-support. Many support groups are currently meeting virtually, so even if you're not in the geographic area of the group, you may be able to attend remotely. You can find our support and other programs going on throughout the month by going to our calendar online. Go to myotonic.org/calendar/month. MDF's video resources are available at our Digital Academy. This includes past Ask the Expert webinars like the one we're in today, which is also being recorded and will be added to the Digital Academy. You can find this and other videos at myotonic.org/digital-academy. This is not the only Ask the Expert webinar we're doing this year. We have a few more coming up. We're very pleased to offer in July a DM and palliative care webinar, and in August, a webinar about disability rights, future planning, and special needs. You can register for future Ask the Expert sessions at myotonic.org/ask-expert-series. All Ask the Expert series are on third Fridays at noon Pacific. In addition to Ask the Expert, MDF offers a fantastic educational webinar series called Meet the DM Drug Developer, where you can learn from companies that are working to develop drugs in myotonic dystrophy. You can hear directly from those organizations at our Meet the DM Drug Developer events. Future events include a July 1st meeting with Avidity Biosciences, a July 22nd event with Harmony Biosciences, and an August 5th event with PepGen. Please register in advance. During registration, you can include questions for our Meet the DM Drug Developer panelists. And of course, you want that RSVP, so you don't forget. Register at myotonic.org/meet-dm-drug-developers. In case you haven't heard, the MDF annual conference is coming this September, as it comes every year. This will be a fantastic two-day event to unite the community, care, and cure for myotonic dystrophy. Registration is now open, and the early bird rate ends this June 19. That's this Sunday if you're watching this event live. The event itself will take place Friday, September 9th through Saturday, September 10th. There will be 5 educational tracks for DM1, DM2, juvenile onset adults, caregivers/self-care, and a track for professionals. A number of session topics include symptoms, research, rights, exercise, grief, and much more. Register for the MDF annual conference at myotonic.org/2022-MDF-annual-conference. I'm very pleased to introduce one of MDF's great friends and champions, the amazing Sarah Howe, who will be our presenter, our expert today. Sarah Howe has worked in myotonic dystrophy for 15 years as the program manager for the Marigold Foundation. Marigold is a private Canadian foundation focused on therapeutic development, research, and strategic initiatives in myotonic dystrophy. Recently, Sarah was project coordinator for the Christopher Project, which you will hear about in today's webinar, which was a large survey of patients, families, and caregivers living with DM1 and 2. And the project was aimed at understanding their unmet needs and elevating the patient voice in myotonic dystrophy. Sarah was very careful to say in preparing for today's presentation how we are flipping Ask the Expert on its head, because indeed you who are listening, who are living with myotonic dystrophy or a family member, today you are our experts. You'll get to meet Sarah in a moment. Please support the MDF mission. If today's program speaks to you, please consider showing your appreciation with a donation to MDF. Together, we are changing the future of myotonic dystrophy. You can donate at myotonic.org/donate. Now, please join me in welcoming Sarah Howe for today's Ask the Expert series.
Thank you for the kind introduction, Mike. And Clede, thank you for your technical support. Hi, everybody. My name is Sarah. I think Mike gave you a good overview of who I am. That I work for the Marigold Foundation in Calgary, Alberta, Canada, and that Marigold's been focused in myotonic dystrophy for over 15 years. Our work focuses on supporting strategic initiatives in myotonic dystrophy, and I want to emphasize today that understanding the needs of patients and their families is central to the work that we do. And I should just take a moment to shout out the people in the audience who I may have had the opportunity to meet, who I may know. I can't see you, but it's nice to be here with you today. Throughout today's presentation, I'd like to talk to you about patient-centered research and why it's important. I'll also talk about ways in which patients and families can share their experience and use the results of 2 studies, the Christopher Project and a claims data project, to show the value of this contribution. I'll touch on opportunities for moving forward and then respond to any questions you may have, or we can talk about whatever you want to at the end. So as Mike said, this session is called Ask the Expert, and really people living with myotonic dystrophy are the experts in this disease because you live with it every day. Your voice is important, and as experts in your own right, you can inform research, drug development, and government decision-making as essential partners. This is especially true in rare complex diseases like myotonic dystrophy, where physicians may rarely see patients with this disease, and the size and diversity of the patient population presents challenges for recruitment and participation in research projects and clinical trials. So given the rarity and variability of myotonic dystrophy, we need to gather data from as many sources as possible. And the lived experience of patients and families adds critical context and insight. This insight is necessary to increase our shared understanding of the disease itself. It also improves clinical care, where patients are at the center of any effective disease management strategy and can work with their healthcare providers to get the care that they need. This insight also helps guide the development of information and resources for patients and the efforts of advocacy groups to design programs and services that really meet the needs of people living with myotonic dystrophy. It is also essential to any drug development program where industry partners need to understand what matters most to people living with myotonic dystrophy so that they can design their programs accordingly. There's an ever-growing recognition of the partnership role patients and their families play. Advocacy groups, clinicians, industry partners, and regulators rely on the patient voice. So how do we tap into this valuable experience? There are many significant and coordinated efforts aimed at understanding this. For example, some of you may have participated in the myotonic dystrophy externally led patient-focused drug development meeting in 2016 at the FDA, which was spearheaded by the MDF. This resulted in a Voice of the Patient report that was submitted to the FDA to educate regulators on the needs and challenges of people living with myotonic dystrophy. The FDA takes this information into account when evaluating potential therapies for approval. It's critical. Another example is the EveryLife Foundation for Rare Diseases Guide to Patient Involvement in Therapy Development. This guidance helps advocacy and industry partners thoughtfully consider the patient voice as they work together diligently to develop treatments and interventions aimed at improving lives. These are just two examples, and there are many others. Today, I will present findings from two projects, the Christopher Project and a DM Insurance Claims Data Analysis Project. Results from these studies shed light on the patient experience and illustrate the importance of patient-centered research in the development of scientific, clinical, and policy solutions to help improve the lives of people living with myotonic dystrophy. Each study contributes understanding and insight in different ways. The Christopher Project asks patients and families directly about their experience. The Insurance Claims Project looks at the patient journey from a different perspective, gathering data from clinical encounters that were covered by insurance. Both studies provide evidence of the significant burden of disease and validate the patient experience. So let's first look into the results from the Christopher Project. The Marigold Foundation worked closely with other patient advocacy groups, clinical experts, and industry representatives to conduct a comprehensive survey of people living with myotonic dystrophy in Canada and the United States. Each stakeholder group informed the project development and provided significant input along the way. The Christopher Project is the largest patient survey to date in myotonic dystrophy, and it gathered the patient voice to achieve the following project aims. 1, to improve understanding of the complexity of myotonic dystrophy, to explore the unmet needs of people living with myotonic dystrophy, and finally to complement other research, including biomedical research, clinical research, and drug development programs. We used a rigorous methodology and worked closely with many groups, including patients and families. Patients and families were critical in designing and piloting the survey instruments that we used to ensure that we were asking the right questions in the right way to really get at their experience. And I'll just take a moment to reiterate what Mike said. If you have questions as we go, please type them into the chat because we won't be able to address them on the fly. But if you have questions about anything I'm talking about, or it brings up anything that you're interested in talking about, please put your questions in the chat. So the initial patient survey was followed by a family member caregiver survey that included questions across many different domains. Really, we set out to learn directly from you, the experts, about what it's like to live with myotonic dystrophy across the spectrum of the disease, from diagnosis and symptom presentation to managing daily life and accessing the healthcare system. Patient surveys were distributed through advocacy group mailing lists, and follow-on family member surveys were mailed directly to the patient respondents. And all of this was conducted under human subject ethics approval in both countries. Now, I'll talk about some of the results of the study, some select results, so you understand there's so much that came out of the Christopher Project. I won't be able to touch on everything, but there are resources available for you to find out more, and I'll talk about that later. So over 1,000 patients and over 400 family member caregivers completed and returned the Christopher Project surveys. Respondents represented all different types of myotonic dystrophy. I want to thank everyone who participated. Some of you here today may have done so. Your input is invaluable and represents the richest view into the myotonic dystrophy patient experience ever. Now I'll go on to talk about some of the specific areas that we looked at. The Christopher Project asked respondents to indicate whether or not they have a particular symptom. Results show that myotonic dystrophy is highly variable and affects many different parts of the body, and that symptoms place a significant burden on patients and families, not just physical. These results have major implications for daily life, clinical care, and therapeutic intervention. This is the kind of information we need to work together to improve lives of people living with DM. Now, let's take a moment to look at some of the richness of this data. As we look at all of the different symptoms that people report affect them, and kind of the magnitude of people that are affected by them. I think some of you can see yourself here, or some of this may ring true. Some of it may be insightful, especially for things like GI, which is represented all across these results and may be underreported or underappreciated in the clinic. We also get into some of the really severe symptoms that have that need to be addressed, and it's critical for caregivers to understand those patients that experience them. So we can see the variability and complexity and the challenges that people face in their day with managing this disease. We also asked how challenging it is for people living with myotonic dystrophy to manage their daily life activities. Results show that performing daily activities is challenging for people living with myotonic dystrophy, and that getting around effectively can be particularly difficult. They also show that the disease has a significant impact on people's ability to obtain and retain employment. We can take this information and use it to understand areas where we need to focus in order to improve the quality of life for individuals living with this disease. So let's just look a little bit closer. You see these domains, mobility, household, psychological, social, doctor's office. Myotonic dystrophy reaches into all aspects of people's lives. We know that the implications of myotonia are that it's difficult to handle objects. That impacts your ability to eat or to open a door. It really presents challenges, and the more we understand about the day-to-day challenges, the more we can focus on addressing them and improving quality of life. This visual presents the biggest obstacles people face in managing their myotonic dystrophy. It's really what matters most. And I'll hang on this slide for a minute so you can see the scope of what people reported. But really, we see it's obvious that this is a complex condition that affects all aspects of people's lives, and hearing it directly from the patient voice presents a clear message for all of us working together. Finding out in what ways and how often patients access the healthcare system is also important. Results from the Christopher Project show that access to different providers varies among patients, and that there are some critical gaps in healthcare access and clinical care. We know that any effective disease management strategy requires a comprehensive system of care, and we can use this information to see where we can do better. For example, it's positive to see how many folks access their GP and a neurologist and or a cardiologist. But for some of the more complex and less understood aspects of myotonic dystrophy, like GI and respiratory health, the unmet need is clearly evident when we see how many people have never seen a gastroenterologist or a pulmonologist. We all know that information is critical for people living with myotonic dystrophy. Most respondents want to know more about treatments and medications, and over half want to know more about clinical trials. We also see important information needs in areas like nutrition and exercise. These results are insightful and provide direct instruction to the community on what resources to prepare and how important and critical it is to get this information into the hands of patients. So the major outcomes of the Christopher Project are really that it delivers critical insight into what it's like to live with myotonic dystrophy directly from the patient and family member caregiver perspective. It also highlights opportunities to improve health outcomes and develop therapies that address the significant disease burden and unmet needs identified in the study. And finally, the CRISPR Project provides a valuable resource for patient advocacy organizations, scientists and clinical investigators, biotech and pharmaceutical companies, and regulatory bodies. Now, I'll move on to the next study. So the DM Insurance Claims Data Analysis Project was designed to examine large US-based insurance claims databases that contain health economic and clinical encounter data to better understand healthcare costs and medical resource utilization for people living with myotonic dystrophy. Study findings will help to inform the payer case and lay important groundwork for therapeutic registration. And importantly, it also provides additional insight into the myotonic dystrophy experience for patient advocacy and clinical care providers that work to improve health outcomes and quality of life for patients and their families. I'll just take a moment. This study is, I'm going to go into some of the data and it may seem a little bit dry. I'll try and move quickly through it because I don't want to bore you guys. And if you have any questions about this, anything that I may have glossed over or didn't focus on, please ask those in the question box. Okay. So Marigold partnered with IQVIA, they're a world leader in health outcomes research, to conduct a retrospective, observational, real-world study of myotonic dystrophy using their data warehouse. This enormous database included de-identified insurance claims data from all healthcare channels in the United States. It's important to note that these type of data represent a billing code in an insurance claims database. It is not clinically reported, nor natural history data, nor chart data. As such, this data has limitations in and of itself and needs to be interpreted accordingly. That said, examination of this type of data across such a large data set provides an opportunity to look at myotonic dystrophy from a very unique vantage point that complements traditional clinical perspectives and adds to the growing understanding of this rare disease. Now, I'll walk through the study cohort selection process. IQVIA's database is massive. There were over 194 million claimants in the database in 2019, of which 35,000 had at least one diagnostic code for myotonic dystrophy. Consistent with studies of this nature and to ensure greater certainty around diagnosis, patients were required to have at least 2 medical claims of myotonic dystrophy to be included in the study. This resulted in over 18,000 eligible participants. At this point, it's important to note that the ICD-9 and ICD-10 codes, which are insurance classification numbers, it's those for myotonic dystrophy, they don't distinguish between DM1 and DM2, nor the congenital form of the disease. So we can't examine each disease in its unique form. Instead, the study provides blended results for both DM1 and DM2. And in order to illuminate the experience of those claimants who had a very early onset of myotonic dystrophy and who likely have the congenital form of the disease, the overall group was further divided into 2 cohorts based on age. Those 2 years old and older at their first diagnostic code were held in the DM cohort, while those under 2 years of age, when they received their first code, were separated into a congenital cohort for study purposes. These disease cohorts were matched 1-to-1 with non-disease controls, and all unsuccessfully matched patients were excluded. So you can see that we end up with the final study cohorts included over 8,500 in the DM cohort and over 240 in the congenital cohort. These are big numbers. So in that power, we can start to really understand the experience. The study examined a wealth of data, both in sample size and the number of different variables we looked at. We identified numerous variables that we labeled the patient journey in order to better understand what myotonic dystrophy patients experience during their care. The health economic measures included all-cause healthcare resource utilization and all-cause healthcare costs. The study followed the claims history of these cohorts over 4 12-month follow-up periods. We used appropriate statistical tests on the variables that we gathered. And now let's move on to some of the study results. The study encompassed a broad range of claimants. The average age of the DM cohort was 46 years, and the average age of the congenital cohort was less than a year old. Most of the study participants had third-party insurance, and the study did examine the experience of significant number of Medicaid and Medicare claimants. Now on to some of the more deeper findings. So given the complex clinical presentation of myotonic dystrophy, we pulled data on all existing comorbidities. And comorbidities are really the other conditions or diseases that impact the people diagnosed with myotonic dystrophy. We didn't limit the study to a pre-selected list of possibilities, but looked at all potential codes. We found that both DM and CDM cohorts presented with an elevated comorbidity profile compared to their control groups across all 4 study periods. This was most significant in the congenital group. Rich comorbidity data emerged in all major symptom areas that normally impact people living with myotonic dystrophy. The data also show a clear progression of disease and through an increasing comorbidity profile over the 4 study periods. Now this table shows the most impactful comorbidities for the myotonic dystrophy cohort. This data revealed an extensive number of issues that DM patients encounter in medical care, providing considerable insight into the multisystemic nature of the disease. This list represents those that affect more than 5% of the DM cohort with an incidence at least 2 times greater than the control group with a significant p-value. You can see how this data complements the clinical understanding of myotonic dystrophy. Several major symptom areas are present. We see GI, cardiac, sleep, pulmonary issues, and we can understand the complexity of the disease, the variability of the disease, and the progression of the disease over time. The congenital group results are even more striking. Again, we see that these youngest study participants are impacted across many body systems and are affected significantly more than their matched controls. That's this fold change. The complexity and severity of this neonatal form of myotonic dystrophy is clearly evident. And I'll just give you a moment to look at some of the major issues that these newborns face. It's a great complement to the clinical understanding of this disease as well. Another major aim of the study was to examine healthcare resource utilization, commonly known as HCRU, and I'll use that acronym. This helps to provide important context to the claims costs. So what are the insurance companies covering? What are people using that is being covered? An examination of HCRU for the DM cohort in the first 12-month follow-up period shows a consistent pattern of higher usage rates when compared with controls across all metrics of use. This includes the average number of prescription fills, outpatient visits, physician office visits, ER visits, and hospitalizations. A similar examination of the congenital cohort shows even higher usage rates when compared with controls, as exemplified in the average number of prescription fills, outpatient visits, and physician office visits. To highlight one piece of data, the average number of outpatient visits for the congenital group is 70 per year compared to just over 8 for the control cohort. The pattern of increased HCRU for both DM and CDM continues across all 4 study periods. Finally, the study looked at the costs, the total all-cause costs, which summarize all claims-related costs for patients across their medical encounters. As highlighted, the average total all-cause cost for the DM cohort for the first 12-month follow-up period is over $16,000. That's US dollars, significantly higher than their controls. This holds across all contributing cost factors and across all follow-up periods, as we'll see shortly. Interestingly, median total all-cause costs are lower than the mean, and the standard deviation is quite high for the DM cohort. I won't go into detail about how to look at those numbers, but it really provides evidence that there's a subset of people in this study who have extremely high costs. The CDM cohort has markedly higher average total all-cause costs compared to controls across all cost categories. ER visits and hospitalizations are dramatically higher than controls, and it's apparent that a hospitalized congenital patient costs much more than a hospitalized patient who doesn't have congenital myotonic dystrophy or early onset myotonic dystrophy. As for the elevated comorbidity profile described earlier, the very high costs of the congenital cohort are illustrative of the complexity of the disease and the significant needs of patients with this most severe form. So now let's take a moment to look at how average all-cause costs change over the patient's claims history. This graph illustrates the total all-cause costs of the DM cohort compared to controls over 4 follow-up periods. As you can see, costs for the DM cohort were substantially higher than both the control and the US national average. Additionally, the trajectory of costs, that is how they move over time, increases, which is consistent with a progressive neuromuscular disease. Costs for the control cohort, although, approach the US national average over time, as would be expected. The total cost findings for the CDM cohort are even more dramatic. Total average all-cause medical claims costs were more than $60,000 higher than controls in the first 12-month follow-up period, and significantly higher than controls across the study. The extremely high initial costs, followed by a stabilization over subsequent periods, reflects a pattern of early acute clinical needs of people born with myotonic dystrophy. I want to emphasize now that this claim study does not provide a complete picture of the financial burden of myotonic dystrophy. It doesn't include expenses absorbed by individuals and family members out of pocket that aren't covered. Additionally, they don't include any of those services for which insurers won't pay and may exclude important and necessary items like uninsured aids, assisted devices, home health care, non-insured expenses, and loss of work or income due to myotonic dystrophy. And I'll emphasize as well that the study doesn't include the voice of people who have not yet received a diagnosis for myotonic dystrophy, nor those that have declined to receive a diagnosis of myotonic dystrophy. They don't have an ICD code for this condition. And they have decided not to do that for fear of losing their insurance or other potential negative outcomes. So this is a clear and representative voice of myotonic dystrophy, but really only a partial picture of the needs and experiences of all people living with myotonic dystrophy. So to conclude on this particular project, the tremendous amount of data we examined in this study found an elevated comorbidity profile for myotonic dystrophy that clearly demonstrates the complex and highly variable nature of this disease. Study also found that healthcare resource utilization per patient per year was considerably higher for both cohorts compared to their controls across all usage areas. Further, myotonic dystrophy and congenital myotonic dystrophy cohorts have higher annual all-cause healthcare costs when compared to controls overall and across all cost categories. These findings help demonstrate the burden of myotonic dystrophy on patients and families, the burden it places on the healthcare system, and the challenges and burden it places on the payers. So I'll take a moment to bring this all together. The CRISPR project provides insights directly into the day-to-day life of people living with myotonic dystrophy. The insurance claims project provided a more objective view of the claims experience of people living with myotonic dystrophy. Both studies demonstrate the significant burden of this disease and provide insight that can inform advocacy, clinical care, therapeutic development, and government policy. And, importantly, both studies validate the patient experience and complement the clinical picture and are valuable resources for our community. I will take a moment to say that printed or PDF copies of the CRISPR Project report, which is over 75 pages and includes all the results of the study, are available from the MDF at info@myotonic.org, and data from both studies, the CRISPR Project and the insurance claims data, are available to qualified investigators, and you can just contact me at Marigold if you want to find out more about that. So what does the future hold? Really, we don't have all the answers yet. Individuals and families living with myotonic dystrophy are the experts, and the community will continue to rely on your insight to inform and guide research into this complex disease. You have an important role to play. There are many ways which you can actively participate to share your insight. Engaging with advocacy groups like you're doing today, attend meetings and share your experience. You can register in patient registries. you can join natural history studies, and you can participate in clinical trials. I hope my presentation today will inspire you to share your experience and look for opportunities to contribute your voice. So with that, I'd like to say thank you to the MDF and to Mike Nathan and Cleed for all of your support, Knoppen, I should say, and a special thank you to all of the experts in the audience. Together we can really make a difference. Thank you very much.
Sarah, thank you so much for that wonderful presentation. We do have a number of questions for you, and I'm very pleased to be able to share them with you now. We have one with respect to DM2. This is a longer question, but it connects to the claims data information.
Okay.
So the situation is this. The individual is someone living with myotonic dystrophy type 2. Their biggest issue is heart arrhythmia, which is clearly in their case related to their DM2. The person says their visits to a cardiologist are listed as a pacer check measuring atrial flutter, etc., which implies that all DM2-based claims may be missed. So the question is, because they look like pure cardiology issues, so is that true? Would a claims data study of this kind miss DM2 cardiology visits?
So please ask any follow-up questions if how I'm responding to this doesn't hit the nail on the head for you. But to address this, it is a little bit complicated. So the myotonic dystrophy ICD code is attached to the individual in the study. So once we have recruited them through that ICD code into the study, we are able to capture all claims associated with that individual. The only way that their cardiac claims would not be present in the study is if they themselves are not present in the study. So to answer your question, I think I'm answering your question when I say the cardiac claims in our study are reported for people who have the code for myotonic dystrophy. Therefore, if you're in the study, we've got your cardiac claims. A question that I have is, are you concerned that some of the claims data doesn't capture the richness of your experience because it's with a cardiologist and not a neurologist? I think that's what you're getting at, and I would just reiterate that if someone has a code for myotonic dystrophy, all their claims history is captured in the study.
Thank you, Sarah. I think an additional question is DM2, type 2 specifically, if the codes account for both types, DM1 and DM2, if there are separate codes and so on.
The code for myotonic dystrophy does not distinguish between the two types. There is no individualized code for myotonic dystrophy type 2. We know that there are unique diseases, and each group living with their own condition has specific needs, and it has specific medical claims history. With a study like this, and because the code doesn't distinguish, we can't report those things separately.
Thank you very much. Another question, what do you think are the most valuable takeaways from the results of this study, or from either study, for providers to understand?
So really that's critical. And I think because myotonic dystrophy is a rare disease, many physicians encounter one patient and it's the first one they've ever seen, or maybe a family of people living with this disease, and they're confounded by its complexity and unknownness and rarity. And I think the Christopher Project specifically provides a really good overview of the scope of myotonic dystrophy and walks providers through what the patient experiences and what the needs are of people living with this disease. So the report itself and the findings from the study can really be used as a handbook or a checklist and a kind of a body of rich data that providers can use to help people do better with this disease, to address all their needs, to impose a comprehensive system of care, and to work together. Does that answer that?
Yes, thank you. Are there any distinct similarities between the demographic features of both studies?
Very much so. That's a great question. Because what we found is the average age in the Christopher Project study is around 45 years of age, and the average age of the claim study was around 46 years of age. And I may be off on just a year or two there, but we found that definitely that the cohorts are comparable. And even though we can't connect the data sets, I think the claims data reinforces the CRISPR project data, and the CRISPR project data informs how to interpret the claims data. So there is they're representative of the population of people living with myotonic dystrophy in the United States. As normally an adult onset condition, progresses over time. We've captured the folks living with this disease in both studies.
Thank you very much. Besides the two great studies that you have discussed, what are other good ways or opportunities to understand the myotonic dystrophy community better?
So I think organizations like the Myotonic Dystrophy Foundation are constantly reaching out to the members in their community to understand what services they can deliver, what programs they can offer. They're asking for input from people. They're, supporting the support groups to try and get people to engage, to really understand what the unmet needs are. We've got constant recruitment from academic, investigators and clinicians who want to, study the natural history of the disease. We have industry partners who are initiating clinical trials and recruiting patients and families to those studies. So I think that we're really all in this together, and as a community, everyone can learn from everybody else, and if we partner and work together, we can really do better. Does that get at that?
I sure think it does.
Okay.
Thinking of either or both studies, are you aware of or did you observe any distinctions geographically? Whether it's in terms of the insurance claims data, different things were processed or covered differently or applied for more in greater numbers, or in the Christopher project, whether you saw a greater prevalence of certain things in different areas.
Yeah, and I think some of this data is still kind of inherent in the data set and hasn't been really pulled out by geographic region. But I will say a couple of things to that point. Representative participants, like CRISPR project participants, were representative of all states in the US and in all provinces in Canada. So we got, depending upon the population density of each particular jurisdiction, we got, a representative number of people from, more people from California than we got from Oregon, and more people from New York than we got from Connecticut. But we had representation, I think, from 48 out of the 50 states and from all 10 provinces in Canada. With regards to the insurance claims project, because of the database that we used, I think there was a slight, what's the best way to say it? We were missing input from a lot of the southern and southeastern United States. That a lot of the data that goes into the IQVIA database was more representative of central US, West Coast, East Coast, and there was a pocket that was less represented in our study. There is an opportunity, I think, to look deeper into the results of both projects to understand and to kind of break out the experience by geographic region to understand if there are things that affect people more in certain areas, or if some of the success, for example, of access to healthcare is happens in particular regions, and we can learn from those. But we haven't really looked at that specifically.
Thank you very much. Related question, in terms of what the Christopher Project and the Insurance Claims Data Projects looked at, either collectively or respectively, how did those findings line up with our clinical understandings of the condition? Were there any surprises? Was there anything out of sync with our clinical understanding of myotonic dystrophy, whether it's type 1, type 2, CDM, etc.?
Thanks, Mike. Thanks. It's a great question, and I will enter a caveat that I'm not a clinician, and I'm kind of speaking for what their perspective might be, and from what I think it did contribute. People may, want to add to that or have their own perspective on how, as a provider, it may have added or changed some thoughts. But I will say that myotonic dystrophy is one of those things, and it kind of goes back to the cardiac question offered by a DM2 participant here today, is that, this disease spans all of these domains. But when you go to the doctor, you see a neurologist, or you see a cardiologist, or you see PT. And that whole system of care, you're the only, as a patient, you're the common element in that. And the rest of it can kind of be siloed or disassociated. So I think one of the greatest contributors of this Christopher Project study and the claims study in kind of complementary ways is that it provides a whole picture of the disease, that it can't not be seen as something that requires this collaborative, comprehensive system of care, that it's not just muscle and it's not just heart, that these people, there's a complexity and a richness in their experience that needs to be understood as a whole. So I think that there are providers who think of myotonic dystrophy that way, but there's also a lot of providers out there who don't have the experience to, or even, they don't know what they don't know. And so this has helped really form that for people. I also think that some of the less understood aspects of the disease, like the psychological aspects, especially for the congenital cohort, and gastrointestinal problems, really rose out of the Christopher Project and the Claims Project to demonstrate that these physical issues that people are facing are central to the disease, not peripheral or, they're significant and central to what people are living with. So I think that was another thing that these studies contributed. I could go on. I'll say again that if anyone has any questions about these studies at all after we're off air, you can call me or email me anytime. If any interested parties want access to this data, we can talk about ways to make that available to you as well.
Thank you so much, Sarah. That's exactly the kind of analysis we were looking for. Another question is with respect to interventions, including non-medical interventions. Did we see in, again, either Christopher Project or Insurance Claims Data Project, any patterns of interventions that were either, with Christopher Project reflected to be effective or found helpful from the perspective of individuals with DM or their families?
Well, I'll say a couple of things about that. I think people know, and I think this is where this question comes from, is that there's a lack of options available for people, and anything that they do have access to is a symptomatic treatment or intervention that helps them manage certain aspects of their condition, but certainly not a whole. And we are all here looking towards the day where there are meaningful therapeutics that can actually change the course of the disease, or at least have a significant enough impact that people are managing the whole of their myotonic dystrophy, or even significant parts of it. So we know that we're not there yet. I will say that the medication use reported in the CRISPR project was really low. And we asked people if they take medication for myotonia, do they take medication for fatigue or daytime sleepiness, do they take any medication for GI issues. We saw that the reported use of these medications was low. And then we also saw that for those who do take those medications, that there was a ton of different types of drugs, or even naturopathic, homeopathic interventions that they took. So there was no one thing or one drug that people reported taking. We asked if they were satisfied with the effect of these, for the people who do take any medication at all, are they satisfied with the effect? And really, it was a moderate to slightly satisfied level of satisfaction that they had. So we know there's a huge unmet need for people living with myotonic dystrophy. In the insurance claims, again, we looked at drug, basically prescription fills, the types of drugs that they use, and nothing rose to the top as being, half the people in this claims project, in this database, take this particular type of medication. There was no clear signal there. I'll just mention that we've talked about other interventions as well. So do people use a mobility device? Do they use a wheelchair or cane? Do they have a pacemaker or an ICD? Do they use a CPAP or a BiPAP? And really what we found is that there was no universal picture of access or use of these devices that can help manage symptoms. So it really does emphasize that people living with DM have needs that are yet unmet, and that we need to continue working hard to change that.
Thank you, Sarah. That's a very powerful response. I believe it was during the insurance claims data presentation, there was a discussion or a mention of a clear progression that was identified. Could you just speak more to that?
Sure. So with the claims data, we gathered all these people, on the start date of the study, and they joined the study when they got their first claim. And anyone who got their first claim in that first year would be considered, that's the first 12-month period of the study. And then the next year that they're in the study is the next year that they are living in that claims database with myotonic dystrophy, and then a third and a fourth year. So over that time of these people being tracked through this study, we see an increasing prevalence of certain comorbidities. We see an increasing prevalence of use of certain medications, or an increased number of procedures being performed to support these patients in their clinical care or in the hospital. So over time, you build a picture that is more representative of, and your experience. The first year you have myotonic dystrophy, you look at things this way and you understand it, and then as you move out, your needs increase over time, and you may need access to different types of care and support. And then 3, 4, 5, 6 years down the road, we see this pattern is evident in the claims data set. And it's kind of a complement to the CRISPR project data, because the CRISPR project is a snapshot of the experience of these folks on the day that they completed the survey. What's interesting about the CRISPR project, though, is it takes people from all different times in their condition. So some people responded to the study who had been living with myotonic dystrophy for 15 years. Some people responded to the study who just received a diagnosis a month ago. So it presents kind of a mosaic of the experience of people living with myotonic dystrophy. And I think people can identify with themselves in there. Does that answer that?
I think it does.
Okay.
Thank you.
Yeah.
Without any further questions from our audience, I think we are prepared to wrap up this Ask the Expert webinar. I just want to turn it back to you, Sarah, first of all, with all of our gratitude from the foundation and the community for the work that went into these studies, and then taking the time today to share what you've learned with us and encouraging us to continue to learn more by digging into those studies. But I just want to, ask, what are your big takeaways? What are your final thoughts or comments for all of us?
Thanks, Mike. Thank you. It's an absolute pleasure to be able to speak with you all today, to be here with you today. I think the big takeaway is how much the whole community relies on the patient voice and how important it is to understand this disease from the perspective of people living with it. So that's the big takeaway from this day, and I think from all the work that I do. And so I just want to say thank you, and I want to say I hope one day maybe to see you guys again in person. And just thank you to the MDF for your support, your contribution to these studies, and for having me here today.
Well, it was our pleasure, Sarah. The great Sarah Howe of the Marigold Foundation, a champion for the community and the community voice in research.
Thanks, Mike.
We urge our audience to rewatch this video, which will be recorded and added to our digital academy, to explore the Christopher Project, which is available on our website. We can get you copies of it digitally or in print. To learn more about all of this, and as Sarah said, contribute when opportunities arise. In the design of any kind of study or any kind of participation you can do to add your insights as experts living with myotonic dystrophy and families thereof. We do want to encourage you to attend all of our amazing activities coming up in July, to meet the DM drug developers, and another Ask the Expert webinar. And until then, we hope that you stay safe, and we hope that you have a great weekend. Sarah, thank you so much.